Hi, I'm Dr. Molly Millians. I'm going to talk today on educational care for children affected by prenatal alcohol exposure. I have no conflict of interest to disclose. I'm part of Emory Neurodevelopmental Exposures Clinic. We are part of the Center for Maternal Substance Abuse and Child Development at Emory University School of Medicine. We've been in existence since 1980. We do prevention work. One of our examples of our prevention project is MotherToBaby. It's a warm line for pregnant women and providers to call. They have questions about any kind of prenatal issue or exposure. More of exposure. We do research and development of interventions. One such intervention I will be speaking about today is the Math Interactive Learning Experience and Go Far. That's two. And we also do diagnostics and treatment through the Emory Neurodevelopmental Exposures Clinic. Today, we're going to walk away, hopefully, with some understandings about educational interventions and the impact of prenatal alcohol exposure. First, children with fetal alcohol spectrum disorder, or FASD, do not all present in the same way. The diagnosis of FASD is an indicator or a starting point to really kind of focus what's going on with a child and develop your intervention approach from that. It's a risk factor, but it also may signify some other kind of issues that need to be covered. Educational interventions need to focus on the individual's learning profile. This means to move away from just the deficits associated with a diagnosis, but also look at the individual's strengths to support their progress in order to meet their interventions. Interventions need to target building skills to improve learning and participation, also to improve their self-efficacy so that they can advocate for themselves and function as well as they can independently across settings. More successful intervention approaches really is based upon collaboration between schools, family, community providers, as well as, especially as children get older, the individual who's impacted by prenatal alcohol exposure. Before I get started, I'd also like to talk about some descriptors and clinical terms. We use the term FASD a lot. In the United States, fetal alcohol spectrum disorder is not a clinical diagnosis or a medical diagnosis. It's an umbrella term that includes all the impact associated with prenatal alcohol exposure. It might include alcohol-related neurodevelopmental deficits, which indicates that there is some kind of cognitive damage caused by prenatal alcohol exposure, but it may not be shown in the physical features. The medical diagnosis associated with prenatal alcohol exposure, and I'm going to talk about what we used at the Emory Clinic, are fetal alcohol syndrome, which we call FAS, and that's given to those who not only show the facial features, but have growth delays, the cognitive impairment, and also has documented evidence of prenatal alcohol exposures. Sometimes our clinic will give a diagnosis of FAS if there's no documented exposures. If an individual shows all the impacts affected by prenatal alcohol exposure, and there's no other reason why a child is showing developmental delays, then we might call it FAS without documented evidence. That's not very common. There's partial fetal alcohol syndrome. That does not mean the severity of effects. What it means is that the number of effects caused by prenatal alcohol exposure. A child must have documented evidence of prenatal alcohol exposures to get a diagnosis of partial fetal alcohol syndrome. Another one is prenatal alcohol exposure, which is ICD-10 code P04.3. That means a child is exposed, but may not be affected. We're documenting, in that case, in a clinical diagnosis, we're documenting the effects. Other clinical or behavior diagnosis. In the DMS-5 in the appendix, specific neurodevelopmental disorder associated with the effects from prenatal alcohol exposure, or NDPAE, can be coded by a clinician. That's a DMS-5 code 315.8, and that indicates that there's cognitive impact and behavior impact or adaptive functioning that's impacted by prenatal alcohol exposure that would maybe without the physical features, but with documented evidence that are impacting a child. There is no one test for fetal alcohol syndrome. It's a rule out. So we have to take a look at all the information and rule out whatever we can to determine if a child is infected by prenatal alcohol exposure. So let's talk about the impact of PAE on learning, academics, and school functioning. There are specific neurodevelopmental deficits associated with PAE. These may impact individuals very differently. Some individuals may have global cognitive impairments or delays, which technically are scores on standardized measures of intellectual abilities less than a standard score of 70. Average is 100. Or they may not have those cognitive delays. They may have specific deficits in areas of executive functioning, working memory, visuospatial processing, specific memory, and processing speed. We also know there are problems with self-regulation. That's the ability to maintain a consistent arousal level, or what we call an energy level. This can impact poor impulse control. It can also look like attention deficits. It also impacts behavior regulation. In some cases, it will impact the ability to maintain self-control. We also see challenges with adaptive functioning. That could be language or social communication, interactions with individuals, motor skills, and daily living or self-care skills. When we look at young children affected by prenatal alcohol exposure in early school settings, we might see difficulties kind of regulating or maintaining classroom routines. They may be overly friendly and not have personal boundaries. At times, they may appear very irritable and have trouble calming, and that's due to problems with self-regulation. They may have difficulties with their running or what we call gross motor skills. They may have problems with cutting or using crayons when coloring. That's problems with fine motor skills. They also may have trouble. They may have their quality of play may not be as good as typically developing children. In primary age or elementary school children, you might see difficulties learning to read, write with handwriting as well as mathematical skills. We see difficulties or reported difficulties in a clinical setting of difficulties following teachers' directions. They may call out in the classroom, forget to raise hands, or forget common routines. They may randomly take items from other kids. This may be more related to impulsivity. Other kids with other developmental disorders do this, but these are some of the very common clinical reports we receive. They may have problems staying in their seat or difficulties waiting. Again, that's related to self-regulation. And a lot of times children with other developmental disorders may also have some of these challenges. What we see or what were reported clinically for middle and high school students is we often hear they have poor organizational skills, problem synthesizing information. That means taking an idea and applying it in different ways. Poor social skills, difficulties maintaining a sense of judgment. In other words, they may act in ways that doesn't show good judgment that may get them in trouble. Problems interacting with peers and adults, and difficulties organizing ideas to express their thoughts. Before I get started, I also want to talk about the difference between ADHD and FAS. You may have more than one diagnosis. So you may have FAS as well as ADHD. According to the National Institute of Mental Health, ADHD is a brain disorder that's displayed by pervasive behaviors of inattention, impulsivity, and hyperactivity that interferes with development and functioning. It is more related to underactivation, what we call the frontal lobe. Frontal lobe is also tied to executive processes. You have problems coping with ADHD with understimulation. In other words, individuals may become hyper to rev themselves up because they cannot tolerate the understimulation. And they have problems initiating, in other words, activating and sustaining or maintaining attention over long periods. That's a little different than children with FAS. What we find with the effects of prenatal alcohol exposure is more diffuse brain damage. So it's overall, it's not as specific maybe in an individual with ADHD. They have problems coping with overstimulation. That's what we describe as being dysregulated. In other words, they don't know how to react. They may be more reactive to settings. And then they also have more cognitive problems that look like attention, such as difficulties with encoding. That's the ability to learn. It may take them longer to learn, so they may stare off as they're encoding because they're not taking the information in. It may look like inattention. Visual search, in other words, attentional control. They may have difficulty knowing what to attend to. And then shifting, which is an executive function, is the ability to go between mental ideas or mental sets. That may be more difficult in kids with fetal alcohol syndrome. So when we look at the research on prenatal alcohol exposure in academics, we see across the literature there are chances there's academic underachievement. In other words, when compared to non-exposed peers or peers with some other clinical or behavior diagnoses, such as ADHD, they do not perform as well. Not all children show deficits in academics. They may show lower academic achievement relative to non-exposed peers. Young children may show challenges learning pre-academic skills. We know difficulties with learning numerical information or number sense. Also, in some cases, early reading skills. Scores have shown difficulties on academic achievement measures of word reading and comprehension. We know that there's poor performance in spelling due to weaknesses in some of the cognitive processes, especially a working memory. We do know that there are difficulties in some or different uses of brain patterns and written language skills when compared to non-exposed peers. We know there's poor functional handwriting. In other words, how well you can write to produce work in a classroom setting. And across studies, we do see deficits in math. Classroom behavior is kind of challenging. We do see observation of longer periods of passive or disengaged behaviors when compared to non-exposed periods. In other words, this could be related to something such as difficulties with encoding or slower rate of processing information because they're not able to maintain the pace. Many kids with FAS show prosocial skills and engagement in the classroom, but they do it for shorter durations when compared to non-exposed peers. Again, this can also be influenced by other factors. Teachers report more impulsive or unpredictable behavior and possibly aggressive behaviors in children with PAE. This was noted in several studies, but sometimes when we put into other environmental factors, it kind of tamps down the significance. We do know there's poor quality of play. In other words, their play seems maybe not as rich or not, may be more haphazard than non-exposed peers. We know that kids with FAS really can initiate friendships, but the challenges are maintaining them and negotiating friendships and peer conflict. We also know they have poor adaptive function, which are daily living skills, the ability how well you function across settings that cannot be explained by cognitive ability. In other words, regardless, even if a child has cognitive function within the average range, sometimes they still have poor adaptive functioning. There are other factors that influence learning behavior at school. Experiences of childhood adversity. This can be everything from witnessing domestic violence, neglect, deprivation, multiple foster home placements. Experiences of racism and discrimination can impact children's functioning at school. There are other challenges that may not necessarily be coded as an adverse experience, such as other prenatal exposures. Over authoritarian parenting, in other words, if parenting is very harsh, that sometimes can have a negative impact. Social and economic disadvantage, mental and medical conditions, unattainable learning expectations can also impact your learning and behavior in school. And then inappropriate treatment planning, which may be a reflection of a misdiagnosis, especially if adequate diagnostic services are not provided. So when we talk about that, we can look at barriers to educational interventions that may impact functioning at school. Stigma misperceptions. In some cases, some caregivers have reported being concerned about disclosing a diagnosis of FAS to teachers for fear that they may be judged themselves because of poor parenting. That's even been written up in several studies. Also, misperceptions. There are misperceptions that kids with FAS, because the brain damage, will never succeed. And that's not true. So there may be concerns about the amount of effort to put into a child who has this diagnosis. There's a lack of understanding the range of impact of prenatal alcohol exposure on learning. Children affected by prenatal alcohol exposure will not all have behavior problems. They will not all have self-regulation difficulties or executive functioning problems. Some may not have academic difficulties in math. What they may have are different kind of approaches or different combinations. So there's a lack of understanding really the range of impact on learning that may impact children in a school setting. Some parents have reported challenges having to explain every year the educational needs of their child related to FAS. There's lack of access to interventions reported, which, in other words, and I kind of want to shift this, it may not be a lack of access or may be unaware of comparable interventions. There are a few interventions because FAS is so it's heterogeneous. It's not just one profile. Other interventions may work. It's just knowing how to match the intervention with what your child needs. This is a chart of a collaborative approach for educational caring for children affected by prenatal alcohol exposure. And the reason this came out of an article published in 2014 on educational care, really what we would like to propose, it needs to be collaborative. It also needs to be integrative. What I mean by that, it needs to integrate all elements, not only just school, it also needs to incorporate family, it needs to incorporate advocacy, it needs to incorporate caregiver support. It also needs to incorporate and consider, especially related to education, educational placement. Not all children need to be in a special ed setting or in a small group special education setting or even receive special education services. It needs to be based upon the results from a really good developmental evaluation. What would be the best placement to provide the level of services? It needs to look at the types of classroom interventions. Are there academic, adaptive, social, behavior, all of the above? Or could it be just something such as supports? It depends on the individual needs. And then we talk about school-based services, which could be a range. It could be everything from mentoring, which is not a special ed service per se, to very explicit therapeutic services such as OT, PT, or speech, or medical and nursing if there's some other kind of medical conditions. One thing that's very important and what they show in the literature that is very helpful for children with FASD, no matter what educational setting, is training on the impact of prenatal alcohol exposure, which you have been attending. And that could be not only caregiver training, but also teacher training to understand the range of diagnosis of impact of PAE, but also that might impact school. So given all that, where to start? And I'd like to talk about how to talk about your child's needs. And I'd like to present one approach. There are multiple approaches, but maybe this will give you a place to start. The World Health Organization, their international classification of functioning disability and healthcare of youth and in children and youth, and this has been done in another article by Gorka. I think it's Gorka. What they do is they have kind of developed common language to talk about terms of ability and disability. According to this approach, ability refers to the level of engagement and participation an individual has in an activity. In contrast, a disability refers to impairment that restricts that participation. When you look at the environment, an environment can be anything from the setting where or the type of instruction. Environment may be not only a support, but it also can be a barrier. And the overall goal when we're talking about children's needs is how to improve their functioning and the quality of life. So taking that from the World Health Organization, in 2018, Klein and DiCaramargo developed the Functional Abilities Classification Tool, or the FACT tool. And what this does is this is a way to take the framework put out by the International Classification into a way that may be applied for not only teachers, but other clinicians to really talk about how do we explain what a child needs at school. It integrates medical, it integrates psychological testing in school records when you consider or when you start planning for interventions. It can be completed by a psychologist, a special education teacher, an intervention special, or any other clinician who works with your child. It really considers what an individual can do for engagement and participation, which using the International Health Classification, that's ability. It looks at barriers, which includes disabilities and other environmental factors that can really impact a child's learning. And then what it is to develop goals and support to increase active engagement and participation, which will increase learning in a school setting. So here's the tool. And this is from the article that was published in 2018. On the left side, or my left side, it talks about the levels of classification of participation. That's everything level 1, and that's typically in green, means typical for age range. Level 2 means that there needs to be intermittent support, just a little support. Level 3 means extensive or continual support, and level 4, which is in the red, means the setting's not appropriate. There needs to be more modification. When we talk about the functional abilities classification, what we're talking about skills that are related to school. They talk about verbal, which refers to language. They talk about literacy, which refers to reading, writing, spelling. This is communication through words. Visual, which will also entail nonverbal and spatial, which means how well do they take in their environment, seeing. Executive, which refers to executive functioning. Social, which means social skills. I'm going to step back for 1 second. Executive functioning, and way kind of look at it. This is and what we're talking about is more applied executive functioning. This is problem solving. This is the ability to organize and then to shift or to kind of work through, as well as to inhibit impulsive reactions. Social deals with how well you interact with your peers, and then self-regulation is how well you can maintain calm and modulate your responses in a setting. So functional abilities are the skills that you need to learn in a classroom. Participation refers to how well an individual participates without support, given the different kind of instructional types. In other words, individual work. 1, again, is the typical age range. 2 means low frequency or quality without support. 3 means low frequency, increases in low frequency without support. And 4 means you don't participate unless there's incredible modifications. And then it goes into individual work, multi-stepped group work, teacher directed, which is very important. In other words, that might be a structured activity, unstructured group activity, such as a lunch, structured physical activity, which may be PE, and unstructured physical activity, which may be recess. So it takes a look at all the different settings. It takes a look at the skills that you would need to function in each of those settings and type of demands. And then it also looks at not only environmental supports, environmental stressors, and personal factors. So let's do a quick case review using this tool. I'm going to talk about a 15-year-old girl who's prenatally exposed to opiates, alcohol, and tobacco. This young woman has had multiple foster placements until adopted. She repeated kindergarten. She restarted receiving special ed services in the 4th grade. She received private occupational therapy and speech until the 4th grade. Her recent testing showed that her verbal abilities were in the low average range. Compared to her other skills, this was a relative strength. So that's something to keep in the back of our minds, is that we may need to use her verbal abilities to help with supporting her interventions. Her spatial, nonverbal reasoning, and memory were in the low to very low range. So in other words, when she has to mentally rotate information or recognize patterns and then encode this information or link it with language, it doesn't work very well for her. So we've got to figure out how that's an area that we need to know to support. Academics, reading, and math was in the very low range. So she's having not only trouble with decoding and breaking the and deciphering what she's reading, but also with mathematical skills. Her spelling is a little bit better, but it's still difficult. So she's having academic problems across the board. Adaptive functioning is moderately low to adequate, which again, that shows that she has some skills that need support and other skills that can be used to support her lower skills. She's adequate in her self-regulation and her social abilities, which is a big plus in a school setting. She's moderately low in her use of functional communication and her ability to follow, maintain schedules and to organize and to keep track of everything, especially in her school setting. She does have the diagnosis of full spectrum fetal alcohol syndrome, and she also has a diagnosis to try to capture her cognitive impairments of neurodevelopmental disorder associated with prenatal alcohol exposure. Her educational program in progress, she's in 9th grade in a public school. All her instruction is taught in a special ed co-taught classes with no other supports. Her academic curriculum primarily is on grade level. Keep in mind, this may not be appropriate given her level of functioning. Her grades are D and lower, except in drama. She thrives in her drama class. One thing about her grades is that she's barely passing. She retakes about 80% of her tests and quizzes just to get that minimum passing grades. That's something to really keep in mind when we look at functional abilities on the FACT tool, because that means she's not even making it with intensive support. She needs frequent adult or peer assistance to complete classwork and homework, even to maintain what she has to do for assignments. She does not do well with Google Classroom or some of the other technologies. It's hard for her to read. She's engaged in class, which is very important, which means she's motivated. She's got support. She really desires to do well at school. She's very aware what's going on. She expresses class moves too quickly and she has trouble understanding what they're saying. It may not necessarily be attention. This may be her difficulties in encoding information and maintaining the pace of the class work. She really expresses how much she loves her drama class. She also states that she prefers small group classes. She says she's able to ask questions and able to slow the pace down. Her functional abilities classification and verbal based upon testing not only done through the clinic, but also done through school shows that she needs compared to typical peers in a general classroom, continuous intensive support to understand what's being said in the classroom. When we look at her visual, her executive functioning, that's kind of your concept and your problem solving approaches, literacy and math, and those are her two primary academic classes. For her to function within even her co-taught class, there needs to be significant modifications according to the factual. She's not making it. And that is shown by the multiple failures on her academic classes. It's shown by having to retake her tests. It's also shown by her standardized skills. It's also shown by the number of assignments she's getting low grades on, even when she attempts them on her own, and the amount of help she needs just to get the minimum passing grade. Now, on her self-regulation, that's a level 2. She needs some support, and it's more in relation to what the task demands are what the task demands are requiring. So that we gave her a 2. So she does have some strengths we can work with to support these other weaknesses. When looking at the participation in regards to what the task demand, she has very low participation without intensive modification when she's required to do individualized work, especially if it's on grade level, multi-step tasks, teacher-directed group work, especially if it's in an inclusion setting or in the general education setting for core academics, and on collaborative projects when she's required to work with other students. Now, when she's in, especially with typically developing peers during structured physical activity with PE, she just needs some support. She really holds her own and does very well. That is shown in her participation in drama. Free time, typical range, no support. She does well. She's got friends. She needs someone once in a while to check in with her, especially if she gets into these larger groups, but she does very well and has a good group of friends. So using this, what we did is we summarized all the information we had, and we presented with her instructional team at school is that academic expectations and current placement for core content classes in the inclusion setting or the co-taught setting exceeds her learning level, even with the level of support they're giving. It's not appropriate. She's showing limited meaningful participation in these classes, so that's hindering her learning. So what we suggested is that we requested that they adjust the instructional setting for core content classes. For non-instructional setting and level support, she will participate in non-academic settings with intermittent support, like her drama class. So we may need to continue to facilitate her participation with those interests. And she's full participation without support in lunch and unstructured time. So this really kind of fleshed out where she needs more support and where she can participate within the others. We also know that we need to embed instruction to improve her adaptive functioning and social skills to keep those going so that those get her ready to transition into transition into post-high school training in the settings where she's thriving. So we're using the settings where she's doing very well to increase her skills, which may have some relative weaknesses. We're building on her strengths to modulate arousal levels. In other words, when it's on her learning level, she functions very well. She's able to maintain good sustained mental effort, and she's able to maintain good self-regulation. So we are ready to learn. When it's on her level, we can do it. She's motivated to do well in school, so she's not afraid to ask for help, and she will do the work when it's on her level. Even when it was beyond her level, she tried to do her best. And then she interacts well with classmates. So that's where we can keep her successful to kind of balance out where things are difficult, because she needs to be exposed to situations where she is very successful. So what we did was we put her in a small group special education classes using a functional curriculum on her learning level to meet her academic needs. And non-academic classes in the general ed setting, we focused on giving her some special ed support and just some adjustments. Back to the small group setting, we did request she needed more of a remedial approach for reading and mathematics because her reading was so low. She wasn't at the point where she could really even complete pre-vocational training. And unstructured school settings like drama, We continue the participation with facilitation with support and check in with adult as needed. And from what I understand, she did very well with this setup. And then she started building skills, and then we moved her in as she got older into more pre-vocational training. So I do want to talk briefly about school disability regulations, placement, and services. When you're looking at FASD or alcohol-related diagnosis, it is a medical diagnosis. It's clinical, and clinical is a little different than education. And a clinical perspective will be different than an educational perspective. A clinical perspective, we're looking at terms of relative weaknesses or relative abilities. Typically, we look at terms in regards of within normal limits or within a benchmark. Our evaluations in a clinical setting are validated, reliable, using standardized measures. We use very structured observations and or clinical judgment. It may or may not involve a team of clinicians. And again, person-centered planning, we do try to involve the individual, and we try to involve the caregivers. We look at progress in regards to treatment planning in terms of reaching an optimal level of functioning or reaching closer within normal limits. So in other words, we're trying to go optimal here. We use a lot of diagnoses in the DMS-5 or ICD-10. Those are clinical diagnoses. They're very explicit criteria and cut points. Education concerns in an educational setting, especially for special education services, really must impact academic performance or school functioning. School functioning is defined as the processes related to behavior to function in a classroom setting, social interaction in a classroom setting, as well as academic performance. Evaluations at school are non-biased, just like in a clinical, or try to be as non-biased as possible, as well as a clinical setting, using a variety of sources. These are anecdotal notes, parent reports, work sample, reliable and validated standardized testing, as well as criterion benchmark and informal measures. And what they do oftentimes when you look at needs, or when you're talking about do they meet a need, we look at comparison to classroom performance and then the eligibility. And that is really done by a team decision rather than a clinical diagnosis, which may or may not. Progress at school is measured in comparison to classroom performance, an individual's growth, results on school-based measure or standardized testing, adequate progress that's not necessarily optimal. You do not have, school is not required to provide optimal, they're required to provide adequate services that are available to other kids who do not have disabilities. Special education eligibility exceptionalities are descriptive categories for educational purposes. These are not necessary clinical diagnosis. Even the term autism is a little different in a clinical diagnosis when it's termed, when you're talking about exceptionality for eligibility service in a special ed setting. One other thing that's very important to kind of be aware of the differences is there's a difference between the Section 504 Rehabilitation Act and IDEA, or the Individuals with the Disabilities Act of 2004. Section 504 Rehabilitation Act is a non-discriminatory regulation. It's to protect the individual with a disability from discrimination and provide equal access to educational and all kinds of opportunities for organizations that receive funding through the federal government. It's monitored through the Office of Civil Rights. It does not provide any funding. It does not provide an avenue for funding for services. A definition of a disability, according to 504, is very similar to that with the American with Disabilities Act. What it entails is it defines it very broadly. It's a physical or mental impairment that impacts major life activities. And what this means is this can be a physical or mental impairment that's also in remission or recovery, or one that is recognized. And this can be everything from physical disfigurement to something like asthma, to something like a cognitive impairment. And when we say major life activities, that's everything from transporting yourself back and forth to school, or to even just moving in the classroom in a school setting. All age groups are covered under Section 504 Rehabilitation Act if you're found eligible or if you're found to have a disability. The key elements in relation to school are free and appropriate education. It grants access to adequate educational activities regardless if it's during the school day or after school. Non-biased evaluations to indicate if there is a disability. It safeguards for appropriate placement. In other words, you cannot discriminate someone from placement due to a disability. But what also does is it protects that educational needs need to be provided based upon an individual's learning needs. It does provide procedures to file a grievance against the compliance to 504. It provides for accommodations. It does not necessarily, it provides access to service, but it does not specifically provide that individual service. It is a non-discriminatory regulation. It works in coordination with the Individuals with Disabilities Act. Some covered organizations include after-school programs, elementary schools, educational organizations, colleges, and even some employment. It's an anti-discriminatory regulation. Differently is Individuals with Disabilities Act. This is through the U.S. Department of Education. It does provide services for special education and related services for children 0 to 3 under IDEA Part C, and 3 to 20 to the 22nd birthday, or the summer before you turn where you're 21, the summer before you turn 22, depending on how your birthday falls for individuals. So technically it stops for kids up to 12th grade. It does provide for FAPE. In other words, it provides the services and evaluations for eligibility for special ed services. For children 0 to 3, through IDA Part C, it has an individual family service plans. Those are a little different than an individualized education plan for school-age children that's provided in the public schools. It requires that instruction needs to be put with the least restrictive environment. In other words, to as much as possible, individuals with disabilities must be educated with their non-disabled peers based upon the level of their needs, the individual disabilities needs. It provides for parental and students' rights. It provides access to your records, and also provides due process in case there's a disagreement. Now, there are examples. Not all services are not all services or special education services or resource, but these may vary by states, districts, or schools. So when we talk about multi-tiered systems of support, in IDEA, they do say that multiple ways need to be examined to determine if a child is eligible for special ed services. One such manner are the multi-tiered systems of support, which includes the response to intervention. In other words, they try to do at different levels using a pyramid structure where the base is the whole school and the top of the pyramid is where you referred for special education services, gradually increasing level of services as children, after monitoring progress, may be provided. This is not only to address academic difficulties, but can address behavior. A student support team may be part of this. Some may have student support teams, some may have intervention teams. It may vary by name or according to the district. 504 accommodations are not special ed services. These are just changes to an environment or to adjustments to materials to level the playing field. In other words, to keep the individual within the schools, within the general ed setting, or to help them maneuver a general ed setting, or to function within their non-disabled peers. Early intervention services, this is supplemental instruction often given and provided for schools that work a lot with those lower income areas to make sure and to level the playing field that they're getting the appropriate level of instruction. Social work services, for example, family needs help or support. Before and after school tutoring and enrichment programs. These may vary according to grants and funding sources. Summer school. Summer school is one of those that sometimes you may have to pay a fee. Sometimes it's available if there's grant money available. Sometimes it's provided if you have in a different kind of way. If you don't make a certain score on your end of the year benchmark, summer school may be provided. Mentoring and graduation coaches are for individuals often without an IEP to really help get them to graduate high school. Mentoring can be provided by a whole different range of organizations that may have connections with the school. Some schools may have a health clinic connected to it or mental health services connected to it. You do not necessarily have to have special ed services to access some of these services if they are provided in your school. They're not mandatory. They may be, other schools may have projects going on with organizations, meals and nutrition programs, and social skills and behavior supports. One thing I do want to point out is that there is not necessarily a set number of accommodations within a 504 accommodation plan. Some examples are being seated from, if you're dealing with classroom instruction, is being seated away from high traffic areas, presenting directions one step at a time, giving study guides. You may ask for large print material, fewer problems on a page, copies of notes, and use of common technology, or ensuring that they use common technology. What these are is that accommodations are to level the playing field, but they must not place an undue burden on the educational setting, and that is actually written in the regulation. There are examples of accommodations for attention and organization. Maybe have the teacher help write or check the agenda. Use checklists to help students organize steps to tasks. Break assignments into manageable segments. Extended time, provided that it's okay within, if like for tests, if it's okay within a test protocol, yeah. And use of non-verbal signals to redirect attention. Behavior, you can use behavior plans with rewards that does not necessarily have to come through special ed. You can use a behavior contract. In other words, you could do behavior charts and have a behavior system. These are things that can be put within a 504 accommodation plan. They're not special ed services. And you can ask for supervision in the hallway. But again, the level of accommodations must not place any undue burden on the school setting. Now, when we talk about IDEA eligibility categorizations of special education services, in IDEA, there are 13 categories. I have highlighted or have bolded, put in bold, those that we oftentimes may get some child eligible, given that they meet criteria for services, or I've read in the literature. So significant emotional and behavior disorder, I try to avoid that. That occurs in cases where there's no other, if there are significant behavior problems that need really intense intervention, and there's no other factor that's impacting learning, then yes, we will do significant behavior disorder. Intellectual disability, we sometimes do in children with FAS, especially if their cognitive and their adaptive functioning are less than a standard score of 70, and they have mild to moderate or even profound intellectual disabilities. Other health impairment is one that we use most often. What we're saying with this is that an individual's disability that impacts school is impacted by FASD, which is a medical condition. Therefore, we are requesting other health impairment. For children ages 3 to 9, we use significant developmental delay sometimes. We prefer other health impairment, but this is significant development delay seems to be a catch-all. And so what it's used and it stops at age 9. You have to be eligible under this by age 7. It's no longer applicable after the age of 9. So it's used really for the younger kids. And then specific learning disability, especially with the impairment in math. Now, that's not to say that children with FAS might not fit within one of the other categories. We've had children that had both autism and FAS and have become eligible under autism spectrum disorder. Again, it's eligibility under the category needs to be put upon the individual's needs, but the FAS diagnosis, an alcohol-related diagnosis, will give you a starting point of where to go. So if you have a child who's showing academic deficits or problems in the classroom, who may be eligible for special education services, other health impairment may be a category to fit. Now, this is kind of interesting. I'm kind of excited about it. As of August 31st, California passed their state bill 1016, or what they call the Portano Special Education Bill. It's on the governor's desk for signing. I haven't heard if it's been signed yet. What they did is that now in California law in that state, now it's not applicable nationwide yet, is that FASD is now recognized as a condition within the special education exceptionality of other health impairment. ADHD is often mentioned in there now. California has passed a law that FASD is recognized, which is good, because then that way we can say, yes, it does fit within this. Is it going to match all students with fetal alcohol syndrome or an alcohol-related diagnosis? No, but it's a good starting point. And it's a way to start increasing the recognition of the impact of prenatal alcohol exposure and get the necessary services for kids who are affected by PAE. I want to talk briefly about some special education services. Again, these are a continuum. Instructional settings are everything from self-contained to general education. Now, it is based upon the premise that most children, that you need to be in the least restrictive environment, educated with non-disabled peers as to the most extent possible. That is based upon the level of disability. When we talk about educational related therapies, that means speech, OT, PT, and severe cases, you may need applied behavior analysis. Some schools may provide it, not all do. But again, you need to really see what's available. Specialized or adaptive equipment, direct instruction for hearing and vision impairment, extended school year services if a child does not show progress to their IEP goals and objectives, specialized transportation, and intensive behavior interventions. I'm not talking just a behavior checklist. I'm talking when they really need intensive behavior. That might be everything from hand over hand to behavior modification, and in some cases applied behavior analysis if appropriate. So as a caregiver, when you're considering interventions, you need to look whether it's best to provide these interventions in school. Is it best, or are they available at school? Because schools, again, their job, according to the law, is to educate children within the best of to an adequate level in the educational setting. So if something happens at home that's not impacting school, that is not a school issue. That would be more of a community issue. But if it's something like, for example, school refusal behavior, that's not only impacting home, that's impacting school. You may need some support from school. So you've really got to determine where the interventions are best served. Is it school, community, or both? For example, if you have significant speech impairment, you can get school service, community service, and maybe best to get them at both places, because school addresses school-related speech and language, while a community may do a more clinical approach. So it depends on what the target skills are that you're working with and what's best to be applied. Also, you got to consider if a child, for example, is found ineligible, but you disagree with it, you've got to really, for special ed services, you've really got to consider where's the best effort going to be to make sure your child's needs are met. Will it be fighting the school system, or would it be best to go ahead and divert resources and energy to getting really good community-based intervention services or tutoring or specialized services so that they can do well in their school setting? So on that note, I'm going to talk about some evidence-based interventions that are found effective for children affected by prenatal alcohol exposure. Before I get started, I really want to, my spelling's really bad. I'm just checking it as I go. I really want to reiterate elements of intervention planning. It's based upon each child's development, cognitive, and learning profile. It's better to be developed based upon your child's need rather than just whatever, if you say my child has FAS and you say, well, FAS has this, my child needs that, that's not going to work, because you can have a mismatch. It's really important to match it upon your child's needs. FAS is why possibly your child is having these learning issues. It's a starting point. You really, remember that chart, that really solid developmental evaluation will help guide what you need to do. It needs to target building skills. What you've got to do is get the children active in the learning process, get them to build up the skill, and then embed that skill training within context so that they can apply it. So for example, if you're trying to build number writing, you work with it in isolation, you embed it within whatever you can. For example, everything from writing the date to writing notes, and then you use it and then you take that skill and tie it on to number recognition. Again, this is interlinked. Interventions need to be on the individual's developmental learning level. Going too high may not work. Going too low may not work. Going too low, you actually might get behavior challenges, as well as going too high, because the kid may not understand and they may act out. So that kind of sweet spot is very important. It also needs to be how you're getting them to become active and engaged participants, and get them to become participant in the learning process. So effective interventions may be more about the approach rather than the program. And that's something to keep in mind, is how this child learns is the most important piece, not the program you're using. That's where it's going to be very important to have a very good tutor or intervention specialist who understands the skill, how to teach that skill, and then understands the cognitive range of the impact affected by prenatal exposure. What we use in our clinic is we use a framework based upon Elsevier that's used in cognitive rehabilitation, where we're building skills within the context for application. And then we try to get the children as active as possible to build those individual skills. So for academic skills, and these are in the research, one common spelling approach is what they call cover, copy, and compare. This is something that's not just for FAS, it's used in many kids. And what you're trying to do is get them to attend to specific elements of words. You copy it so they rehearse it. So you're working on working memory. And then you compare what they have them write it. And then you compare it to what they wrote to what the correct written is. Then you can also get them to look at it. So you've got multiple exposures. It's the approach. So this study showed, it was just a case study, was that using this approach should increase number of words spelled correctly. This is used with many kids, and it does work. It's a way to build those skills. Cable clothes and all, this is the math interactive learning experience. This was learning readiness and mathematics. The first study was done with 55 children in the United States, ages 3 to 10. This was one-on-one mathematics instruction that really embedded a metacognitive approach. And what we mean is we made the kids tell us what they see, make a plan before they work through it, tell exactly as they did when they worked through it, each process, and then tell what they did at the end. We used we used manipulatives for the math. We tied it in after they did the manipulatives. We tied it over into a more abstract representation, and then we moved into math, more what we call traditional math skills, or when they had to solve equations. And we did it, and then we showed the parents what we did. What we found is that there were increases in math scores that remained 6 months after the intervention, and we saw improvements with behavior and self-regulation. Teaching kids how to stop and approach a problem is very effective, and it can be done across settings. And a lot of programs do it. Even air traffic controllers do it. They stop, they ask themselves, what's happening here? What do we need to do? And then what's going to be the outcome? Same thing. Plan, do, review. Focus, plan, act, reflect. Goal, plan, do, review. You may hear these in other domains. It is a very good way to help kids develop an internal structure on how to approach problems. Adams et al. In 2007 did a language and literacy intervention pilot with 65 kids, 9 to 10, with prenatal alcohol exposure in South Africa. What they found is that they had interventions to improve phonological awareness, letter knowledge, word recognition, and spelling and decoding. What they showed, there was no change in academic achievement scores, but what they did show was that there was a change in the trained skills. They also showed a little bit improvement in cognitive, what they call cognitive control. In other words, they were better with managing self-regulation. Millians, this is our Saturday cognitive rehabilitation program with ENIC. This was a case study of 5 kids with 4 with FAS and 1 with attention deficit. This was 12 weeks of one-on-one tutoring in either reading and math. We used mental management strategies. All kids were taught to use the focus, act, plan, and reflect approach. What we saw was a increase of at least 1 standard deviation in the academic achievement in either reading or math on 4 of the students. So we did, we got a nice gain. We got 3 out of 5 kids showed significant increases of more than 1 standard deviation in nonverbal reasoning. In other words, they jumped over from borderline, which is a score in the 70s, a standard score of 70s, into the lower average range. We saw an increase. We don't know exactly what caused that increase. We do suspect it was teaching them how to attend and approach a problem on that, in general, they applied it to the nonverbal reasoning. So it showed promise for some application. We don't have direct evidence. We're suspecting it. So if you'd like information about MILE, feel free to email me. For information about other learning activities for children with FASD and other developmental disabilities, do2learn.com has a lot of resources free of charge, and it's a good resource. Self-regulation, through our lab, we did Go Far, and this is several studies have been published on this. This is a metacognitive training, and it uses focus, plan, act, and reflect, using a computer game and then direct parent training to improve adaptive functioning. And what they found is that it has improved self-regulation, sustained attention, and adaptive functioning in the kids who went through the study. It's very important to increase that self-regulation approach. Kearns and all did computerized attentional control training. This was a computer program using one-on-one coaching. And again, I'm going to say that one-on-one coaching, building those skills is probably very effective. It improved sustained and selective attention and spatial working memory, and it did carry over into reading and math fluency. This is a very small study. I've not been able to get a hold of the computer program anywhere commercially. Riley and all did cognitive control therapy, which is that, again, that helps improve self-regulation. What you're doing is you're teaching kids to recognize their own actions, teaching them to self-monitor and reflect, and then teaching them to stop. And what they showed is when they taught children ages 8 to 9 this, they did show improved behavioral adaptive skills, and this was reported at school. So you can teach these self-regulation skills. One program is Copycat for older kids. Find a therapist who works with it, they can use it. A lot of schools have these programs embedded within them. Other self-regulation programs, one is the ALERT program. This is used by a lot of occupational therapists throughout the United States. And the Wells and all in 2012, this was done in Chicago, used the ALERT program in kids with FAS. They did show gains in executive functioning, problem solving, and emotional regulation. Other studies have shown the same outcome. So if you want to know more about the ALERT program, there is a website at www.alertprogram.com. You can find a provider in the area. To access information about GoFar is do2learn.com. There's a computer game there as well as other materials. Or if you'd like more information, please, you can call the ENIC clinic at 404-712-9810. So 404-712-9810. Social emotional skills. Bruin Buddies, which is Best Buddies. This is was a social skills done in 2010 study, and what it did was they really worked with someone on making friends. And what they found is that when they did the social skills training, there were reduced behavioral problems and then less hostile attributions in social settings. In other words, kids with FAS became less agitated and aggressive in these settings, and they kind of calmed down because they knew what to do. This is my favorite. It's a children's friendship training for social skills. This was done by O'Connor and all in 2012. And what this taught kids not only how to initiate friendships, but it worked them through all these different modules, even how to negotiate peer conflict, and then how to kind of walk away from situations. It was very useful. It's parent reported improvement in social skills, and they also showed improvement and more use of more pro-social behaviors. We talked about Elizabeth in the case study about her affinity for drama. Knightley and all in 2018, and that was reported in Flanagan and all in 2020, did intensive theater-based training. And what they found was that there was improvement in self-confidence, peer interactions, and social communication. So yeah, it did within something that maybe a kid would enjoy. They did very well. And then mental health literacy program at UCLA looked at some emotional well-being, and they found when they did this kind of training, or what they called the brain unit, using mental health literacy program and dialectical behavioral therapy, behavioral skill building, and these were older kids. They found that kids made interventions in emotional regulation, interpersonal interaction, and really coping with stress, because a lot of times kids with FAS, they have trouble kind of tolerating distress or coping with disappointment and stress, and this really helped. So the link here for Best Buddies, there is a Georgia chapter if you're interested. The link is on the slide. And then if you'd like information about the UCL Children's Friendship Program at UCLA, the link is there. Now, I do mention that there are examples of other interventions found effective for children with other disabilities that may be appropriate for kids with FAS. One is Airless Learning by Project Learn. This is setting a kid up for success. Activities are set for 80% accuracy. And what you're preventing inaccurate learning that you have to undo. It's really good for kids who may be anxious to kind of know what to expect. It's also really good for kids with working memory problems, because you're really systematically instructing them and preventing any kind of error learning where they're not having to undo. Handwriting Without Tears is a very good handwriting program used with many kids with different disabilities. It's available at www.lwtears.com, and it uses language to help remember the steps to write. Mathematics, dyscalculia.org or Skill Boosters provide a lot of information on how to address different kind of math issues. And then when we're talking about reading, the International Dyslexia Association talks about some effective reading interventions, whether it's coding or some other aspects. If you have a reading disorder, you want to use what works for other disabilities. Attention, behavior, learning, and memory. Harvard Center of Developing Child has some really nice information on executive functioning and activities you can do at home, but also suggestions on how to support your child at school. For positive behavior intervention approaches is PBIS. Positive behavior intervention is very important, especially if kids with significant behavior troubles who need that extra externalized support, and then really how to implement it and pull back. University of Kansas has a strategic instruction model. It's really good for older kids. This includes mnemonics, on ways to kind of remember how to organize information. It also gives strategies on how to teach older kids how to self-advocate. These are very important skills. And again, it's found effective for not only just children with all kinds of learning difficulties. If you want to know more about interventions found effective for other disciplines, the National Center on Intensive Intervention, the website's here, is a very useful resource. Cover, Copy, and Compare is one of them on there. Actually, our math program, the Math Interactive Learning Experience, is also maintained in that database. These are research-based. It goes through a pretty intensive review process, and so they are good. They look at all the studies and determine if they're evidence-based. There are other assistive technology support. If you're working online, ask for electronic worksheets. Those are fill in the blanks. Sometimes they're a little easier than expected, especially kids who have spelling difficulties or written language output challenges. The electronic worksheets or study guides can be very helpful. Talking calculators. I'm not a big calculator fan. I think they don't come into play until you really understand basic until after you've acquired basic academic calculation. But again, in some cases, it is helpful. It depends on what the child needs. Organizational aids, everything from Evernote for older kids to vibrating watches, reminders to move, even to move might be beneficial. There's some suggestions. Graphic organizers gives a visual layout of information. Poplet.com are useful. If you got older kids, use a reusable notebook such as Rocketbook. These are actually kind of nice and fairly inexpensive. What are expensive are the pens you use, but what you do is you write on them. You can take your phone, an application on the phone. It's got a code, you scan it, and it will go to a Google Drive or another kind of drive. It helps take care of notes. So you don't have to worry about organizing multiple things. You just have to worry to make sure the child gets it into the right file. They're electronic readers. Most computers have speech, text, and voice recognition. So see if you can turn some of those on if you need to use technology. Audiobooks are useful. And then phonetic spelling software. If you're like me and can't spell anything that can be picked up on spell check, these are really incredibly helpful. For more information about assistive technology supports, University of Michigan's website is very useful, and Georgia Tech has Tools for Life, which is a local source, and they will actually help you find things that match your child. I can't say enough things about this organization, Parent to Parent. They've even got a database of providers and all kinds of supports throughout Georgia. They give trainings and they put out information on how to negotiate for school services for your children, and they really support Georgia families. The website's there. Use that. They're a good resource. Especially if you have questions about school and want to get in contact with other parents. When I mean get in contact with other parents, about support groups and other parents. So in conclusion, I'm going to stop there. We do know that the effects from prenatal alcohol exposure, individuals are at risk for lifelong challenges. These risks are often compounded by other environmental or other factors or medical conditions, but they vary across individuals. There's not one specific phenotype. There's not one test that will tell you a child has FAS. A diagnosis is important in knowing where to start. It also gives you, as part of this diagnostic process, you can get a really good evaluation. Then you understand where your child's functioning. Interventions, it needs to be based upon a really good evaluation and information, and focus on building skills. It needs to be based upon a collaboration between caregivers, schools, and community providers to improve their outcomes. In other words, as much as you can work together to get everyone on the same page, to not only address the needs at home, but with friends, but also at the school setting, the outcomes are going to be better. And we do know when there is an appropriate intervention, the children with FAS do very well. So I thank you, and I hope you find this helpful.